Hello students. So let us today discuss something a basic topic of the biomechanics of the wrist and the hand. The wrist and the hand functions very much closely as one unit, and it allows us to perform our daily activities and desired function and give result when action in a coordinated manner. And there are many small muscles and small bones comprising the whole unit, so we need to understand the biomechanics of these small bones and the muscles, how they are oriented and how they move in different planes and axes. So first let us see about the articular complex of the wrist. The main articular complex of the wrist contains two joints, the radiocarpal joint and the midcarpal joint. The radiocarpal joint is between the radial head and the proximal row of the carpal bones, and the midcarpal joint is between the proximal and the distal rows of the carpal bones. So here you can see figure. The radiocarpal joint is an ellipsoidal joint, and the carpal aspect presents two convexities, that is the transverse convexity and the anterior posterior convexity. So here in this picture you can see this is the distal radio or ulnar joint, that is the radius and ulna. Here that is the radius and the carpal bones, that is the radiocarpal joint, the radius and the first row of the carpal bones. And this is the mid-carpal joint, that is the joint between the proximal and the distal row of the carpal bones. Then let us look at the ligaments of the radiocarpal joint are the medial and lateral collateral ligaments, and the anterior ligaments attached to the anterior edge of the distal surface of the radius and the neck of the capitate bone. And the posterior ligament, it forms a strap posteriorly. Now the main action of the ligaments is during adduction, abduction. The medial and lateral ligaments are active starting from the rest position. So when you do adduction, the lateral ligament is stretched and the medial ligament goes for shortening or it's slackened. And in abduction, the medial ligament goes for stretching and the lateral ligament is slackened and gets shortened. So during flexion and extension, the anterior and posterior ligaments are most active. In flexion, posterior ligament is stretched. In extension, the anterior ligament is stretched. Now if you quickly look at the muscles of the wrist, the inflection, the flexor carpi ulnaris, the flexor carpi radialis, and the palmaris longus works as our assist in the flexion, and these two muscles work primarily for wrist flexion. In wrist extension, we see extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris. In ulnar division, this flexor carpi ulnaris, extensor carpi ulnaris. Radial division, flexor carpi radialis, extensor carpi radialis longus. So the synergistic and stabilizing action of the muscles of the wrist. Extensor muscles of the wrist act synergistically with the flexors of the fingers. Example, during extension of the wrist, the fingers are automatically flexes or it goes for flexion. And to extend the fingers in this position, a voluntary movement is required. To do the wrist extension in a good range, automatically the fingers will flex. If you try on your own wrist, then you can see that the flexor muscles of the wrist act synergistically with the extensors of the fingers. So when the wrist is flexed, extension of the proximal phalanx follows immediately. If you flex the proximal phalanx and then you flex the wrist, it is difficult. But once you open up and then you flex the wrist, it goes for good range of movement by extension of the proximal phalanx, which follows automatically. Now let us see about the kinematics of the wrist. The articular complex of the wrist has basically 2 degrees of freedom. So when these combine it with pronation and supination, that is the rotation of the forearm around the long axis, the hand can be oriented at any angle to grasp or hold the object. If the forearm and the palm is facing up towards the ceiling, it is the supination, and if it is facing down when you rotate the forearm, or then the wrist or the palmar aspect is facing the ground, it is pronation. So the movement of the wrist occurs in two axes. One is the transverse axis that takes place in the sagittal plane. Okay, with movement flexion, the anterior palmar surface of the hand moves towards the anterior aspect of the forearm. Extension, the posterior dorsal surface of the hand moves towards the posterior aspect of the forearm. Now the anterior posterior axis takes place in the frontal plane with movements like the adduction or the ulnar deviation. The hand moves towards the axis of the body and is medial side, that is the ulnar side, and forms an obtuse angle with the medial border of the forearm. When you abduct, the hand moves away from the axis of the body and towards its lateral border, forms an obtuse angle with the lateral border of the forearm. So this is the diagram that is depicting the abduction and the adduction. The range of movement of the wrist abduction does not exceed 15 degree. Adduction is 45, flexion and extension is 85 degree. And there is one movement called circumduction. Combination of the movement of all these flexion, extension, adduction and abduction takes place in a circular way, two axes of the wrist. Now let us see the stabilizing function of the ligament. Now the stabilization takes place in the frontal plane. The ligaments are essential because the distal surface of the radius faces distally and medially, so that as a whole it can be represented by a plane running obliquely proximo-distally and medio-laterally. Under the pull of longitudinal muscles, the carpus in the neutral position tends to slip proximally and medially. You can see in this figure. When the wrist is adducted to approximately 30 degree, the pull of the muscles now act as perpendicular to the plane of the slippage. As a result, the carpal bones are pushed back into the cavity and the carpus is stabilized. This you can see in the figure 6. So when the wrist is abducted, the pull of the long muscles attenuates the instability and it tends to displace the carpal bones proximally and medially. So how does the stabilization takes place in the sagittal plane? It is roughly similar events here also, but because the distal surface of the radius points distally and interiorly, the carpal bones tend to slide proximally and interiorly, that is in a plane parallel to that of the distal surface of the radius. This is figure 7 depicting in the neutral position of the wrist. When the wrist is flexed to 30 to 40 degree, muscular pull tends to displace the carpal bones in a plane perpendicular to that of the distal surface of the radius, thus repositioning and stabilizing these bones. That is in flexion. In figure 8 it is depicted. During extension, the tendency of the carpal bones are to be displaced proximally and anteriorly is reinforced, that is in extension. So the full brunt is borne by the two radio-triacutal bands of the anterior posterior ligaments of the radiocarpal joint. As they run obliquely, proximally and laterally, they keep the carpal bone in position and prevent their medial displacement. Now, what are some of the abnormal movement? Some anatomical damage is most often caused by abduction and extension, and often in combination. Abduction, it past the locked position, causes two types of damage. First is fracture of the distal end of radius, fracture of the scaphoid. Scaphoid is pressed against the lateral buttress of the distal radius, that is the fracture of the distal end of the radius takes place. And sometimes the radial styloid strikes the lateral surface of the scaphoid, which fractures as a result of the shearing forces. Extension, when exaggerated, most often causes a Colles fracture. When someone falls down with the wrist in support, it goes for a wrist extension, and extension position, it goes for the Colles fracture, and more rarely it causes damage to the ligaments with primary rupture of the lunatocapitate ligament and secondarily perilunate dislocation, anterior dislocation of the lunate. So in the perilunate dislocation, the lunate maintains its normal articulation with the radius, but the capitate articular surface is dislocated from the lunate, normally dorsally. And in the anterior dislocation of the lunate, when the head of the capitate moves proximally towards the radius and displaces the lunate anteriorly into carpal tunnel with compression of the median nerve. Another common injuries in wrist hand is the boxer's fracture, that is the metacarpal fracture and mallet or drop finger deformity resulting from the injury at the distal interphalangeal joints among the football receivers or the baseball catchers. There is also a forced abduction of the thumb leading to ulnar collateral ligament injury, often resulting from wrestling, football, hockey, and skiing. The another disease we can see is the decubitus disease, that is the tendinitis of the extensor pollicis brevis and the abductor pollicis longus, seen commonly in golfers. Another condition we can see is the carpal tunnel syndrome. The carpal tunnel is actually a passage between the carpal bone and the flexor retinaculum on the palmar side. From unknown causes or from repeated forceful wrist flexion, usually this is the onset is swelling caused by acute and chronic trauma leading to the median nerve compressions. So symptoms like numbness along the median nerve, clumsiness of the finger function, eventually weakness and atrophy of the muscles will take place supplied by the median nerve. So this is about the wrist. I hope you got some idea about the wrist biomechanics. Now let us look at the another component of that unit called the hand. The hand is the of the man is a remarkable instrument capable of performing countless actions owing to its essential function called prehension. So from the functional viewpoint, the hand is a factor organ of the upper limb, which supports it mechanically and allows it to adopt the optimal position for any given action. So the functional position of the hand, we keep the wrist extended 20 degrees, ulnar deviated 10 degrees, metacarpophalangeal joints 45 degrees, proximal interphalangeal joints 30 to 45, and distal interphalangeal joints 10 to 20. Thumb, the first carpometacarpal joint partially abducted and opposed. Metacarpophalangeal joint of the thumb is flexed at 10 degrees, and the interphalangeal joint of the thumb joint is flexed at 5 degrees, which will give to this kind of a position which is called the functional position of the hand. So in this functional position, maximum actions are derived or accomplished, and that is why it is named as the functional position of the hand. Now let us see some of the type of grasp. Two types of grasp actually we can see, that is the power grasp and the prehension. In the types of power grasp, we can see the adductor pollicis stabilizes an object against the palm, and the hand position is static. It is not dynamic, it is static. So we can see cylindrical grip, the first grasp in a small diameter, cylindrical, spherical, hook grip, lateral prehension. So the hook grip, the MP joint extended with flattening of transverse arch, the person may or may include the thumb in this grasp. Lateral prehension, this can be a power grip if the thumb is adducted, prehension grip if the thumb is abducted. Now precision muscles are active here that abduct or oppose the thumb, and the position of the hand is dynamic. Palmar prehension, tip to tip, lateral. Palmar is pulp to pulp, includes chuck or tripod grips, and tip to tip is the FDP, active to maintain DIP flexion, and the lateral prehension is pad to side, that is we call the key grip when we hold the key. The muscles of the hand and the actions, if we see, abductor digiti minimi abducts the fifth digit, abductor pollicis brevis abducts the thumb, adductor pollicis adducts the thumb, extensor pollicis brevis extends the thumb at the metacarpophalangeal joint, flexor digiti minimi brevis flexes the metacarpal and the metacarpophalangeal joints of the fifth digit, flexor pollicis brevis, it flexes the metacarpophalangeal and the carpometacarpal joints of the thumb. Flexor pollicis longus, it flexes the metacarpophalangeal and interphalangeal joints of the thumb. Introsal muscles, palmar introsal, lumbricals, opponent digiti minimi, opponent pollicis, and palmaris brevis. So you can read out the actions which they perform. So these are the muscles you have to keep in mind of the hand. And the mechanism of for the finger flexion, the range of motion in the PIP joint is greater than 90, and in MP it is 135 degree, and DP it is slightly less than 90. The PIP is proximal interphalangeal joints, DP is distal phalangeal joints, MP is metacarpophalangeal joints. So the plane of movement of the flexion of the last four finger is worth discussing because the index is flexed in a strictly sagittal plane towards the base of the thenar eminence. The axis of the fingers during the flexion all converge to a point corresponding to the radial pulse. So this can occur if other fingers are flexed not in a sagittal plane like the index but increasingly oblique. So here you can see the finger flexion. The little finger shows maximal obliquity of this plane of flexion, and the significance of this oblique lies in the fact that it allows the more medial fingers to oppose the thumb like the index. So here you can see the little finger, the obliquity. Mechanism for finger extension. So when we can extend the proximal interphalangeal and distal interphalangeal joints without extending the metacarpophalangeal joints. But we can't extend the PIP joint without extending the DIP joint and at the same time. Flexing only the PIP, distal interphalangeal joint, without so flexing the PIP joint is difficult. So you cannot flex only the distal interphalangeal joint. You can try on your hand without flexing the PIP. So that is full active or passive flexion of the PIP joint prevents active extension of the DIP joint. Tendinous structure comprising the extensor mechanism. The extensor digitorum communis tendon attaches by a tendinous slip to the proximal phalanx through which it extends the MP joint. The central tendon proceeds dorsally to attach to the base of the middle phalanx, where tension can extend the PIP joint. Lateral bands proceed on either side of the dorsal midline and rejoin before attaching to the distal phalanx, and tension in the lateral bands extend the DIP joint. The extensor hood surrounds the MP joint laterally, medially, and dorsally and receives tendinous fibers from the lumbricals and introsa. You can see in the figure here. So although the extensor mechanism fibers are tendinous and therefore incapable of producing active force, they still transmit force to their attachments. The force develops in the extensor mechanism in two ways. Many of the hand's intrinsic muscles attach to extensor mechanism. Activity in any of these muscles produces force that the extensor mechanism communicates to the distal attachments. The extensor mechanism develops passive tension whenever it is elongated. So when the hand movements that passively elongate either the extensor mechanism or a structure that attaches to the extensor mechanism produces force in the extensor mechanism itself. The extensor mechanism fibers have lines of applications that are always dorsal to the lateral axis of PIP and DIP. Therefore, activity in the intrinsic muscles that attach to the extensor mechanism always produce DIP and PIP extension. Passive flexion of the metacarpophalangeal joint elongates the extensor mechanism, extends the PIP and DIP joints. The fibrous lines of application in the hood and the lateral bands that pass very near the MP joint's lateral axis. So when these structures move the MP joint in sagittal plane, it depends on whether the MP joint is already flexed or extended. In MP extension, that is in metacarpophalangeal joint extension, action in the extensor digitorum extends the MP joint and also pulls the extensor mechanism, including the hood proximally. In this position, the interossei muscles lines of the applications are very close to the MP joint's lateral axis. With such small movement arms, these muscles have little effect on MP joint movement in the sagittal plane. However, they still produce MP abduction when the MP joint is extended. The thumb plays a unique role in the function of the hand. The thumb movement includes extension, that is position of reference, flexion, adduction, abduction, and opposition. It has 5 degrees of freedom, 3 for coincidence of the point of contact and 2 for full coincidence of the planes of the palps. Opposition is the essential movement that the thumb that brings the palp of the thumb into contact with that of any finger made of 3 components, that the anteposition, flexion, and pronation of the osteoarticular column of the thumb. Stability of the metacarpophalangeal joint of the thumb depends not only on the articular surface but also on its muscular cuff. Abnormal position of the hand and fingers, this can result from overactivity or underactivity of the muscles described. So the following conditions cause abnormal position, like tearing of the extensor expansion, rupture of the extensor tendon just proximal to its insertion in the third phalanx, rupture of the extensor tendon just proximal to metacarpophalangeal joint, paralysis or rupture of the flexor digitorum sublimus, rupture or paralysis of flexor digitorum profundus tendon, paralysis of the interossei muscles. Other abnormal deformities are, like I described before, dipterence contracture, shortening of the pretendinous fibers of the central palmar aponeurosis, the finger are irreducibly flexed, Volkmann's contracture, that is the ischemic contracture of the flexor muscles, finger assume hook-like position, massive ulnar drift, that the fingers are markedly deviated medially, mainly seen in the rheumatoid arthritis. So the clinical appearance of the peripheral nerve injuries: in the median nerve is injured, then it is due to the carpal tunnel syndrome. There is wasting of thenar eminence, then the decreased thumb function, especially opposition, thumb moves into plane of palm. If the ulnar nerve is damaged, then you can see the wasting of the web space and interossei spaces affects the strength of intrinsic muscles of hand, so the person cannot hold a piece of paper between extended but adducted fingers. Affects the adductor pollicis and ulnar head of the flexor pollicis brevis. A person who lacks strength in these muscles cannot grasp with the thumb unless he or she flexes the IP joint by substituting with the flexor pollicis longus. Paralysis of the ulnar nerve produces claw hand. If the radial nerve is injured, that is associated with gunshot or stab injuries, fracture of the humerus causing the Saturday night palsy, wrist drop, where the person cannot reposition the thumb. Lack of wrist extension may cause hand grip to be weak. So for reference, you can see the book Kapanji, which I've taken, and the physiology of the joints, the book Kapanji, New York Social Livingstone. So students, I hope you got some idea from this video about the biomechanics of the wrist and the hand, as these both the units move synchronously and in coordination to give us the desired movement of action, or we can perform any task by the coordinated way of the wrist and the hand, and both the components closely associated, composed of small bones and small muscles. So we have to understand the biomechanics, the basic biomechanics, how the bones and the muscles are organized, and what is the plane, what are the axes they work. So we saw some of the basic things like the functional position of the hand, the muscles, how it is organized, how the force acts, and what are the muscles working in the direction of the axis and the planes, and how the hand, functional position of the hand, what are the degrees of angles that each component, the MP, PIP, DIP is moves, and how the PIP, DIP moves in coordination with the MP, and so on. So when you first read this, watch this video, you might feel a little clumsiness because it's the biomechanics. So refer your chapter in the book, see the video again, and try to understand. The basic idea is to understand the biomechanical part of the wrist and the hand. So any doubts, you are most welcome, and thank you for watching this video.